tell us about your right thumb and how it hurts
Yes.
you and etc.
Yes, so I kind of know the problem already. It's this joint that tends to go like this whenever I hold a pencil or if I make orthosis. And I try to work on it as much as I can to keep it this. And I also use the brace when I can, but I can't do it with patients. Yeah, so it's really want to go like that.
Okay, and why can you not use the brace with patients?
I'm not allowed to because I can't wear anything on my hands for hygiene.
Okay. Yeah, that's certainly much more strict than it would be in the United States. So you can't wear anything.
No, not even tape.
That is quite a quandary because, okay, well, let's assume you can, just for the
Yes.
sake of learning today. Okay.
I do a lot of drawing as well, and I usually wear it then.
Okay, and does that resolve your pain?
Yeah, it helps a lot.
Okay, good.
Yes.
Well, let's have you tear some paper for us. And what I'd like for you to do, keep your eye on this,
Yes.
okay? And hold it up like that. And try to keep your right hand where it is and do all the tearing with your left, so your left will
Yes.
move. And I don't want you to think about your thumb.
Okay, that was my question.
Okay.
If I should do it right or wrong. Okay.
Okay.
So if I don't think at all.
Don't think at all. And I want you to tell me something about yourself. Tell me what's your favorite. You said you draw a lot. What do you draw?
Yeah, I draw hands actually, hand
Oh,
injuries.
Okay, well,
Yeah.
do that as fast as you can. How fast can you draw a hand?
Well, it depends. The outlines takes about a minute. If
Yeah.
it's complicated, it takes like 5 hours. Oh, I can't do this.
Oh, you did? Okay, that's enough.
Okay.
It hurts me to watch you.
It didn't
Okay.
hurt. It was just difficult.
Okay. Okay, but you felt very weak
Yes.
when you did that. Okay, do you know which size you wear?
A 2,
Okay.
I think.
And have you squeezed it?
Yes,
Okay.
sometimes.
Sometimes. So I'm going to, let me show them. I'm going to open this up, okay, and put this on her hand like that. Great. Okay, now let's make sure we get it all the way down and close this. Now, she's going to relax for me, but she's going to have her thumb on the side, just gently. She's not going to pinch at all, okay?
Yeah.
You're relaxed. And then I take my hand like that, and I try to save my joint, so I'm squeezing with this hand and using my thumb, okay? Does that
Yeah.
feel good?
Yes, it felt very good.
Okay, now let's watch her tear the paper again. Try to stay, yeah, that's good. Okay, now tell me something. Where do you live? How far away?
I live in Stockholm.
And
in Sweden.
Okay, so you've come from Stockholm.
Yes.
And where do you work there?
I work at Hand Center in the city.
Okay, what do you see? Stop, that's good. What did we just learn?
It reduced the adduction of the thumb.
It's reduced the adduction, but what does she do with her MP and IP joint? She's in the exact same pattern she was before, and because that's her definition of loading her thumb. Now, I'm going to be really intrigued. Let's see if we have something that fits here. This is just odds and ends that I've brought with me.
Oh, should I keep it? Oh,
that
sorry.
on. Yeah, okay. Okay, now you were hyperflexing, right? You were hyperextending.
Yes.
Right? I think that might go on. What do you think? You
Should I wear it on?
okay?
Yeah.
All right. Now tear another piece of paper for me. And tear it as fast as you can and tell me something different. Have you enjoyed the course?
Yes, I
What's
have.
the biggest thing you've learned?
I'm kind of overwhelmed with all the knowledge.
Okay.
But it's been great. A lot of great lectures.
Okay, question. This is not really holding her in IP flexion. This is not ideal, okay? So I'm going to see if I can add just a little something.
Sorry for being difficult.
No, you're a good example. I don't know, I don't have exactly what I need. That's good, okay. Let's just see if we can make a difference here. Now, this is just trial and error, okay? This is just play. But I am now going to stick this underneath, trying not to cut the sharp edges. Now, okay. Now you cannot extend fully, right?
Yeah.
Okay. Let's try the paper one more time. And I can tape that down if you need be. All I did was slightly flex her IP joint. Do you see a difference? Am I crazy? Now look, she just flexed her IP joint. She did not do that previously at either time, did she? Okay, that's fine.
Yeah.
That's fine. Okay, so what have we learned? We have learned that the CMC brace, she's already said it helps her. She already uses it. But what I just learned is it does not really help her under load, does it? Because she reverts back to MP flexion, IP extension. And let's approach that one other way and see if that makes any difference. What we did was the IP joint, and that was helpful. But let's now see if preventing MP flexion will help. So I just want you to slide that inside it. You can do that
Like
better
this?
than I can. Or from the bottom, probably.
Yeah.
Because it's, yeah. Okay. Now, this is something I had molded, just really on my thumb. Let her get that in there. And the length may not be right for you, but let's see. Okay. Now I'm not allowing her to flex her her MP joint of her thumb so much. Let's have her tear again. Hope we don't run out of paper.
Am I holding it right? Are you seeing?
I'm not going to tell you. You just do it.
No, I was just thinking about the
Oh,
camera.
no, I'm watching that,
Yeah.
so don't worry.
Okay.
They can see. They can see. That's really good. What do you see? Now,
I'm sorry.
oh, that's okay. It's fine. It's fine. Don't worry. It's really
I'm so
old.
sorry.
No. Go on. You're fine.
No, I'm sorry.
Okay, but what did you see with just that much? Now that she's broken it.
That was awful. I'm so sorry.
No. It's fine. But do you see how either putting something at her IP joint or blocking her MP joint really demanded that she use her flexor pollicis longus during that activity? Was that clear? So I would leave it probably to her choice as to which was more convenient and more comfortable, which she wanted to try. And I would certainly have her do that during your drawing, because her brain has literally forgotten her FPL. And she's probably half my age. We won't go into detail. So she has many more years of loading her thumb. She's already having some pain.
Yes.
So she is the perfect example, I think, of just thinking about it and even working on exercises. It just doesn't get it when this is her pattern. It's so ingrained in her motor memory, and that's what she reverts to even when you stabilize her CMC.
And this was really comfortable until
Until
I
you
broke
broke
it.
Well, all you need to do is get some, you see exactly what that is.
Yes.
It is nothing more than a small piece. And see, it's not molded to you.
Yeah, yeah, because
But-
it was a little bit slippery, so I was gonna
Yeah,
adjust it.
That's fine, that's fine. But you can now make one for yourself
Yeah.
that will do exactly what we just did.
Yeah.
And you need to allow some MP flexion. You know, you don't want to fully extend it because you're going for that arch. And see how you hyperflex there. You don't want to have to do that.
Yeah.
You want to flex some small amount. Okay.
Nice, thank you, and I'm sorry.
Well, not the volar plate, because she's not hyperextending. I'm sorry. You said volar plate. She hyperflexes her MP, and then she hyperextends her IP. So it'd have to be the volar plate of the IP. Okay, look at this. Can you see her MP joint here? See that? That's her normal translation.
Yay.
She is Miss Loosey Goosey everywhere. You're absolutely right. I am, however, I tend to be more concerned for the first, the fine motor, because that's more common, I think. You know, certainly what she does with her artwork. So I would probably focus on that first. But yeah, anything you can do to stiffen up would be helpful to you. And
Yes.
that's the opposite from what we usually want to be stiff. We usually want to be flexible.
Yeah, it's a problem overall, like
Okay,
with
but
my
you're
wrists
paying
and-
attention to it, and
Yeah.
you're aware, and you're doing as much as you can to keep your thumb going. Yes, but it also goes back to, I don't want to immobilize any joint. I want to stabilize. So she still is allowed to move her MP joint into extension and flex until she hits the block. She does have hypermobility the other direction, but if you were to put her in a brace that included both the CMC and MP, then that would probably limit her ability to grasp larger objects. It's a trade-off. I mean, it goes back to the trial and error, where I think we would confer together and she would choose something, and then she needs a period of time to try it and to see how well that works for her, and then see if we need to modify it or have something different. I mean, it's not a nice square box where everything fits, usually. And she's generally hypermobile.
Yeah, I have some pain in my CMC joint for some years when I'm using my hand. Like
At
when
work?
I'm at work and when I'm in the garden and when I'm cooking and something like that.
Okay.
But it's not the whole time, it's just, coming.
It's just coming, so
Yeah.
it's occasional.
Yeah, it is.
Okay. But can you relate it to that, like if you do something all day long, then you know you've done it?
Yeah, but not always. Sometimes
Okay.
it's just random,
Okay. And are you right-handed or left-handed?
right-handed.
Okay. So let's approach her a bit more logically. Now, what I'm going to do here is the radial. Okay, I'm on her trapezium, and I'm pushing. I have to push really pretty hard with my index finger. She is very stable. What you're seeing moving is skin, not bone, but you can't really appreciate that. Then I'm going to, let's see if we can get you. Okay. Now I've got hold of her first metacarpal, and I'm going dorsally. Oh, and she's solid as a rock. Okay, so she has a very stable CMC joint. She does hyperextend her thumb MP. She has what I would say about the normal range of motion. Let's see if she... And that's pretty normal for the MP joint. You'll notice that our first lady really had a lot more than that. Could you tell the difference? You normally have a some translation at your MP joint, okay? Her IP joint is stable. And she does hyperextend normally. Okay. Tear a piece of paper for me and do it just as fast as you can. Don't think about your thumb. Tell me some great secret that I should know.
I don't know.
You don't know a secret? Okay, hold this hand still.
Yeah.
Okay. Okay, now hold it right there. Do not let go of it. Okay, and turn your hand over there. Okay, and now pinch hard. Okay, you can see, yeah, let's get right there. She does not bring her first metacarpal over, does she? I mean, she's really nicely extended at her CMC joint. Can everybody see that? In other words, relax for me now. Let go. Yeah. She does not come over like that. See, she really doesn't have very much CMC. Totally let go of everything. There you go. Let's get rid of that. Okay. That's interesting. She cannot physically go beyond her second metacarpal. That's her passive flexion at the CMC joint. So we know she has this phenomenally stable CMC joint, but what do you see? We really see the same pattern we saw in our previous person, don't we? Where it's really an IP and or an MP matter of collapsing. So the same would be true. Would you be able to change your pattern if you could not hyperextend your IP joint? See if you can slide that on. Is it too little?
Yeah, maybe.
Okay.
No.
You may not get it off.
No.
Okay.
Like
There's
that.
always soaping.
Yeah.
Okay. Now let's do another piece of paper and see what we get. Oh,
I'm not good
wait a
at
minute.
this.
Wait a minute. Wait, you need this. She's still wanting to hyperextend. Did you see that? Okay. I'll
A
try
new
that.
one. Yeah.
Yep, that's fine. Okay, let me just ask you, do you feel stronger?
Yeah, maybe. But it's a bit painful.
Hmm?
It's a bit painful in the CMC joint.
Interesting. And you know why I think it's painful? I think she's loading it more. Don't you think? She stays beautifully abducted. She does not adduct. And she also stays in a great position at her CMC joint. Let's just see if by chance this makes any difference.
I was just wondering whether she was coming down into her outer limits of CMC flexion, because you're now putting the IP joint in.
But her outer limits of CMC flexion don't even bring her
Down
over
to
her
close.
second metacarpal. I've never seen this before. You have a unique thumb. Okay, just try this just odd paper here. You've already
Yeah.
started with 4
Yeah.
or 3 layers, yeah. Any difference?
Yeah, it's not painful anymore. Oh, sorry.
Oh, that does make a difference. So and you told me, did you not, am I correct, that you've been doing stabilization exercises?
Yeah, I have.
Yeah. And so can you share with us what you've been doing specifically?
I haven't done it regularly, but I have done. I have done some exercises for my first
dorsal?
yes,
Mhm.
and I have done just focusing on keeping this watch when I'm using my thumb, and I'm just trying to have the control.
Okay.
Yeah.
Well, tell me again when you see. Here's the quandary. It bothers her intermittently. So, what's her motivation? With all due respect, To do anything if it bothers her intermittently. It's very difficult to have the motivational level to wear both of these, for example, and you would need something different here
Yeah,
that has
yeah.
more flexion. But it would be very difficult to have her do that for a long enough period of time to really make a big difference. But it would be possible, in my opinion. So here's this great quandary of when is it worth it to an individual to invest what is needed to make a change in the pattern of motion of the thumb? I don't think you're quite there yet. No, I'm trying to be very honest and very realistic.
That's right. Yeah.
You know, you have a busy life,
Yeah.
your thumb hurts intermittently, so what would cause you to wear this all day, every day, you know, and she can't wear it in the clinic. So this is real, this is life, this is how patients present to you. But the education of what she needs to do to change her pattern, and the fact that I really wasn't sure that putting this on would change her CMC pain, but it did. So I think her CMC is the stiffest CMC I've ever seen. I'm serious. You haven't had an injury of any sort.
No.
It's just very unusual. Let's see if your other thumb is as stiff. No, look at that. Let's get up here so everybody else can see. Sorry. Okay. Look at this. See her loosey-goosey? That's more than skin. That's a little bit bone. And see that? I mean, that's still very secure. But she had none of that on the right side. So why is there a difference in her CMC stability? I don't know the answer to that. But you're very stiff over here. And so it might even be worthwhile to see if some gentle stretching, both in extension and flexion, not to the extreme by any means, but to see if you can get slightly more mobility in your CMC joint. I don't know. That would be pure trial and error. What do you think? Do you think that would be worthwhile for her? She does have, I would bet, more motion over here. See the difference? See how far she comes over? She cannot do that on the right. So no two thumbs are the same. And yet, when we ask her to pinch and tear the paper, she looked very much the same as the first person, right? But she's not, is she? It takes kind of nibbling down the layers. Well, I hope that was a little helpful.
Well,
I do think this would be the ideal, but it's very hard to replicate. You'd probably need a silver ring,
yeah.
you know, to fit you. Now, Ulrika has an unusual problem. She had a distal radius fracture, a Smith's fracture actually, and she had a volar plate and she had a pin through the first metacarpal. Am I correct? So we're not really looking at Ulrika from the point of view of CMC osteoarthritis because that's not her complaint. But we are looking at her thumb biomechanics, and I just thought that was still worthwhile, okay? Because of all audiences, usually there are many folks have CMC symptoms. You're the elite group, had very few. Okay, tell us about your thumb, but let's get you hooked up here.
I had a radius fracture, and I'm operated, and I had 2 pins like that 5 months ago, just like that, and I had a little fracture on my processus ulna.
Ulnar? Mm-hmm.
So initially I had I was casted and pinned like this for 3.5 weeks, and then I couldn't stand it any longer. So I had the surgeon pull the pins out, and I got cast instead. And then I got to move my thumb like that, but it was quite like this after 6 weeks of immobilization. So I've been working quite hard just to make the position, but now it's quite good, I think.
Okay, let's look at, put both hands up there if you would.
Yeah.
Okay. And raise both thumbs toward the ceiling like you're hitchhiking and turn your hands over. So,
Yeah, so
okay,
it's
so
still
that's about
lacking.
equal.
Almost,
Okay.
yeah.
All right. And then turn them back on the side. And now flex both hands for me. Both
Flex.
thumbs, I mean, sorry. Okay.
So it's still, it feels tight.
And straighten. Okay. And turn your palms up and do the same thing. She has more motion in her injured thumb than her uninjured. See that? She flexes the MP joint more. I'm a little flabbergasted here. It's interesting. Okay.
I had to really work on getting the thumb from this position to the right, just to lift it up, to be able to flatten my hand
Right,
onto a
right.
table, for instance.
And how long has it been since you could really start on your exercises?
It's been almost about 3 months ago.
Okay. I'd say you're doing very well. So let's just see. She has an extremely stable CMC joint, as you would expect. Extremely. She hyperextends her MP passively, but she only flexes that much. Very stable, because I get a nice secure feel there. Relax for me. And look, she has very little play at her MP joint. Let's see how much your there. That's part of it. I think your FPL is adherent. Let's see. Okay, her thumb is down here, and I can take her interphalangeal joint into, let's do it this way. Okay, I'm bringing her thumb across her palm. She has that much interphalangeal joint motion. Now I take her wrist and her thumb, and keep your elbow down, into extension. Oh, it's not that tight. Interesting. She lacks IP joint hyperextension, which she has over here. Interesting. So, if she came in and she were a CMC osteoarthritis patient, and you did this exam, where would you start? Just pretend, okay? We're just going to make this useful. I would start with the CMC joint. That's where her pain is. That's what we're pretending, is complaining about. And so I would put the push Metagrip on her, make sure it fit her, and see if that relieved her pain. Because she doesn't have any great pathology. But let's see what, just out of curiosity, what she does under load, and see if that would change our mind. Because often this will change my mind. Keep this hand still so that the camera can see you, and tear with that one. That's perfect. And do it really as fast as you can. Don't think about it. That's good. Some people are better than others. It's fine.
I'm just fast.
But look what a lovely arched pattern she has. So if she did come in and she said, look, you know, I had this distal fracture, blah, 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 but it hurts here, and it hurts at her CMC, then I would think that she would be the person who needs only the CMC. And she would probably only need it intermittently as she's working through a rehab. I don't know. That would be a trial and error. Does it all kind of fit together? Okay. Well, thank you so much. I think you're doing great with your thumb.
Yeah, but it's still tight. But the anatomy information that we had in the handouts before the lecture, it was really good because I never really thought so much about the volar muscles attaching to the
dorsum.
But that's I can feel that's my problem.
Yes, you're very thick and firm throughout here.
Yeah.
I think a lot of massage and I think time is your best friend.
Yeah.
Yeah, I think you'll do great.
Thank you.
Yep, thank you. It could be, yes, it could be, yeah. She's not, she's only 3 months, so she's not gotten everything back exactly.
Okay, thanks.
But since we were focused on the thumb, I tried to stay away, just for time, so. Okay, tell us about your thumb, but let's give you this first.
I have been having problems with my left thumb.
Okay, let them see it. There you go. Okay, looks really great, doesn't it, her left thumb? Tell us
For
what-
about 2-3 years, actually. But in January, February, I think, so on, I can't remember if I was skiing or something, but my thumbs, the pain increased. And I suddenly noticed also that I felt like my metacarpal is coming.
You felt like your metacarpal was,
Coming.
it was more prominent?
Yeah.
Yeah,
prominent,
okay.
Yeah.
Okay.
And I have been having some issues at work. I'm right-handed, but anyway, I stabilize with the left hand,
Right.
so it's quite problematic. I have been trying to use the push, and I feel it's okay, but my thumb is getting tired after some hours, and a colleague of mine made gauntlet splint for immobilize the MCP as well. Yeah.
And when do you wear
Or
that?
stabilize the MCP.
When do you wear that versus the push? I don't quite understand. You made a gauntlet,
Yes.
and when do you wear that versus the push?
Less pain with the gauntlet.
Okay, I'm so sorry.
That-
I'm confused. Okay. You said you wore the push brace, and
Yeah.
you said that helped, but
Yeah.
your thumb gets tired in it? And then you put on the gauntlet?
Yeah, just to try difference. In some situation, I think the push is better, and in other situation, I feel like I need some stabilizing here on the volar side of my MCP.
On the volar side of your MCP. Okay, all right. Well, let's look first at her joints. Okay. Now, you're seeing a lot of skin move, but I'm getting a nice firm stop right there. So she's really not terribly loosey-goosey. That's in the radial aspect. And even the dorsal. She's like a rock there, so that's not your problem. Let's look at your MP joint. I would say that's kind of the normal amount of translation. She doesn't seem to be hypermobile. She does hyperextend normally. That's her. And she hyperextends at the IP joint. But you're not. Okay, so she has reasonable, now her MP joint's a little laxer there. Does that hurt? Okay, so she has some pathology at the MP and the CMC. Interesting. Let's see your other hand, just for curiosity. Do you notice, or do any of you notice, put your hands out like that again. Can you appreciate the difference in the size of her thenar eminence on her left hand versus her right? Am I making it up? It looks larger to me. Am I wrong? We have no way of measuring it. It looks like you have really well-developed thenar muscles here. So, okay, I want to see now, will her first metacarpal go across? And yes, it easily goes across. See how far I can get it across that second metacarpal? You have to pretend you know where it is. Okay, let's watch you tear paper, if we may.
Okay.
And keep this hand, this is your pathological hand, keep it still, and tear with the right. And try to stay in there. Yeah, okay, it's fine. What did you just notice? As the paper got thicker, did you notice how she became more and more adducted?
I can see it.
I think it's because she feels that her MP is unstable. And so in order to really load, you need to get your thumb in there to have some, you have to have it against something to stabilize it.
Yep.
Yeah, it feels that way. Okay. So the question then would be for you, and this is only a question. This is probably too big, but let's see. Oh, sorry. It's reflection. That probably will not, that's too big, so that won't do anything for you. I don't know that I have anything that is going to work, but let's just see. Huh. Will that go on, or am I crazy? Look at that.
Perfect.
Some days you're lucky, aren't you? I don't think, you can just leave that there. Okay. Let's have you tear paper with that on, and I might just, let's tape that down, I think. So that we can get a good evaluation, because that strap is not the right length. Okay, let's just see, just sheer curiosity, what happens at your CMC? Can you tell any difference?
It's still painful. But
I
I
would-
feel more,
You feel more secure?
yeah.
Okay, let's see if we can get this off. Let's see if preventing your IP extension, see if that fits, or is that too small? I've got a larger one.
Yeah, okay.
Try that one.
Maybe that way.
Yep.
Yep.
Okay. Let's get you a little flexed, like everybody else. Okay, there. All right, now let's tear the paper. Thank you.
I feel stronger.
Did you say that louder?
I feel stronger.
Now, this is not ideal because it does not flex her very much, okay? And were we to give her something where she was slightly more flexed, I think she'd be even stronger. Isn't this a hoot? So I would really, are you hurting at your CMC joint?
Yes.
Okay, so maybe what you need is the push and the IP together. Let's put them on, okay? Are you a size 2, do you
Yep.
know? Okay. Now, before you put it on, make sure this is open, because I want to squeeze it on her to fit her, not the previous person. Okay. All the way down. Snug, but not terribly tight. And then, to save my joints, I do that.
Smart.
Yeah, okay. That doesn't we could fit you a little bit better. But let's try it out. Does that feel good?
Yeah.
Okay, now try the paper, see if that's any different. How do you feel now?
Better.
So it's not really your MP, is it?
No. I can't the rest.
Well, I really learned something today. Because I would have, after looking at your hand and watching, I would have never thought it would be the IP. But do you see how everything depends on everything else, and it's really all three joints we need to look at and influence? Is that helpful to kind of change your way of thinking? Okay.
It's all about the balance.
It is all about the balance.
Yeah.
And there's no way to know without watching you and interacting with you, and you know, there's no way to prescribe ahead of time. You come in, you look like that, we do this. That just does not work because, like I said, I'm really surprised that the IP flexion gives you much more. But what the IP flexion has done is it's changed the way your MP joint is being loaded. So I would really try to get a small, I know you can get them here in Norway, like the silver rings in the US, but different, and have one that keeps you flexed. I think you'd be shocked how much positive influence it would be on your thumb over the long term. And I do think that, you know, this is another perfect example of, and maybe I'm wrong, you know, I could be wrong, I have been wrong, but stabilization exercises, I don't think are the way to change her brain as quickly as putting her in something which does not allow her to fall in her old, quote, pathological pattern. Now, if she has something on her IP joint of her thumb all day long, she's doing what's new and she's repatterning the brain. But if you allow her to fall back in the back, it sort of cancels it out and she has to start all over. So it is really about repatterning a brain. And, you know, I can't keep names and thumbs straight, but, you know, who else were we working on literally just finding the FPL and activating that in the brain? The FPL works, it's just she doesn't use it very often.
But I felt also when I got both the push and overlate, I felt like I could push with my pinch grip.
You had more power?
Yeah, and I don't have any pain when pinching. So normally I wouldn't pinch hard because I know it's painful.
Right, okay.
So,
I think it's just, even though you have some slight instability at your MP joint, I think it's just the way you're loading it that creates this kind of cascade. I'm excited. I think you can really make a difference. You're never going to be able to increase pinch strength without increasing the load on the CMC. Rule number one. So, you know, I would go back to these, excuse me, these same principles and really try to figure out, okay, where is their weakness? I mean, Brigitte is the good example. She is weaker in her thumb and she knows that, but she has no pain. These individuals are weaker in their thumb, but they have no pain. But they probably, and I would put a lot of money on it, that they have some imbalance, and that's why they feel weak. So if you take that individual and you then just say to them, tear the paper or squeeze this or pinch this or whatever, they're going to load their thumb in the weakest way. Does that make sense? And so they're going to continually repeat what has already created the problem. And so you're not only not going to move forward, you're going to probably move a little bit backwards. So I think the same look and evaluation is very relevant. And not that they would wear a brace forever, but maybe they wear a brace during certain really heavy resistive exercises if they want to get stronger, so that they are strengthening the muscles in the balanced posture. Now, if you are not using braces and you want to exercise someone, you have to start by just maintaining the posture with almost no resistance at all. And that's when it becomes hard, because they're not being very productive. You know, you don't see much happen, you can't measure it, blah, blah, blah. But if I pinch too hard and I then become pathological, that's totally useless. So I have to start with just being able to stabilize, and maybe it's just placing things as I'm in the stable arc position, and then you increase the resistance of that. I sometimes use, the tear test is not a real true test in the definition of the word test. It's really just a way to observe load. And so I will often say to the patient, well, go home and get a piece of paper and tear it, and really pay attention to your thumb and staying in the posture, and count how many times you put it back and doubled it. And when you get to the point where you're tearing and your thumb collapses, stop, and then whatever the last number was, that's your exercise point, and work on 4 or 5 days, 2 or 3 days of tearing that many times and staying stable through that many tears. Then once you can do that for a few days, then add one more. And make sure you're stable, and only add another when you don't collapse by adding another. And that's a way just to grade up. It's not, it's not measured, but it is increasing resistance. I would either order for us it would be called a silver ring, but it has to have flexion built into it. Yes. And these little plastic things are straight. This is simply to figure out what we need. That's all it is, yes. Right? And I have I often, the silver ring splints for us are relatively expensive, and they're a long-term purchase. So I often would make one out of thermoplastic that looks like a silver ring. You just have to put a little stay on the side to make it strong enough so you have a triangle shape. But let them test that out to decide if the expense of the silver ring is worth it to them. Nice. And then shift to the silver ring, yeah. My immediate answer is it's no different than the finger, and that is, if my MP joint is stiff, all my movement's going to occur at the CMC joint first. And then the MP is going to get very little. So I have to block the CMC joint and not let it move forward. And you can do that by molding something dorsally and coming around. You can put the push splint on it, and that will do it. But you just need to not allow the CMC to use up the excursion, and then they will have more distally. Yes and no. If you've gotten to the point where you are pathological and you have an imbalance, then it does solve that. But the problem is that we say it burns a bridge, meaning you can't go back and change that. So that, to me, would always be the last decision. If you think about it, particularly when someone is hypermobile in all of their joints, you take one joint away, you're just loading the other two. So I always try to find a way to block the motion rather than to take away the motion. It's not illogical, your thought, at all, but I think particularly in a young person, I would be a little hesitant what the long-term price would be for them. Well, when the trapezium is removed, either it's removed entirely and nothing is put there, and they just, they expect then what happens is there's the bleeding, and the bleeding creates healing tissue and creates new collagen. And so they think of that as a pseudo capsule. I'm not sure I would ever want that done, for the only reason then the thumb has no base to sit on. And what happens over time often is the first metacarpal actually drops down. And in some patients that is not a problem functionally, and in some it is a significant problem. And that's why they started doing, the anchovy procedure, where they put a tendon in as a way of filling the space. And if I had to have surgery, that's probably what I would choose. But it goes back to the whole reason you've done surgery is to reconstruct the joint and to make the joint stable. And so the post-op rehab is, to me, it's just really simple. You just protect it. And not many surgeons think about this, but the push is the perfect brace because you can still move, but you're only moving mid-range. You're staying in abduction, which is important, and as you're loading, you are using the muscles in that stable posture, and that's what rehab is all about. So it's, I sometimes feel embarrassed because, people have these elaborate post-operative protocols, and I'm thinking, what am I missing here? Because I think it's really simple. And maybe I oversimplify it. I don't know. But for someone who has had a joint that needs reconstruction, they almost always, I would guarantee, have had some sort of postural instability. And so the muscles have accommodated to whatever that is, Let's just imagine for a moment, you saw Brigitte's thumb. Just imagine that she needs to have her CMC either replaced or have it, a trapeziectomy. And you saw her posture. So if you saw her post-operatively, what is embedded in her memory of how her thumbs moves is her old posture. And so the trick is to not allow that individual post-operatively to resume that old posture. And an adult relearning how to move their thumb is a really major event. So, and that's why I always fall back to the bracing, because that means that they're never falling back in the old posture, and that you are doing that repeatedly for a number of weeks for them to really change their thumb. And, I'm my own proof that it can be changed. Exactly how long, I can't tell you. I don't know. I always think something. So the first thing that comes to mind is if we took everyone in this room and we had a spectrum on which we could place them as to how much hypermobility they had, we would range the spectrum in this room. And yet we all are, quote, normal. Okay? So hypermobility is relative, first of all. So someone who has a hypermobile thumb might not be at all hypermobile compared to the next person. So let's define hypermobility. That would be my first thought, okay? And the second thought would be human tissue responds to the stress we apply to it. That's who we are as therapists. We're stress appliers. But you remove the stress entirely, and human tissue stops growing. The collagen bundles change, the actual lubrication of the cell interface changes, everything changes, chemically, mechanically. and joints do become stiff. But you have not changed the nature of the collagen. It is still collagen. You reapply stress to it, and it goes back to its normal ability to stretch and relax, etc. That's the nature of collagen. So my thumb is a good example. Before I wore the orthosis, my MP joint hyperextended more than it does now. But the reason it doesn't go back to extending more is I don't allow myself to ever get in the position to load it, okay? I mean, I'm very protective. I pay attention. I wear the brace when I need to, and I don't sit around trying to do it. So I did make a change in my thumb, but I'm not on the end of the hypermobile spectrum where I have collagen that's really relaxed and very elastic. So it's an interface of a lot of variables as to how useful immobilizing a joint would be in an individual who is truly hypermobile. I don't think it'd probably be worth the time and energy. In the long run, in the short run, perhaps. I don't think you'd lose anything. You know, you're not going to harm anyone. But the CMC joint is, of all the joints in our hand, the most hypermobile, just normally. And so you can never do any harm by immobilizing it because it's so hypermobile. You'd like for it to get a little stiffer sometimes. So you noticed the one gal I said, I've never seen a CMC joint with that much limited motion. I mean, she's unusual. Well, that's exactly what I was trying to say with using the bracing. The bracing only, the reason for the bracing is to only allow you to stabilize with the balanced posture. So you have no opportunity to do it the wrong way. So you do repeat it over and over. And so what I say to the patient, it depends on how important this is to you. You need to choose, but this is what I would do. And it is their decision. But if you want to change how they act automatically, then every time they act automatically and they do it wrong, the brain is experiencing that. So you're just canceling out everything you've been trying to do. So it's just kind of like, why would you do that? I mean, you know, I'm just sort of a tough, maybe you'd say a tough personality, you know. Let's just do it right. Let's get on with it. Let's focus on this. Okay, this is inconvenient. Okay, I'm sorry. There are a lot of things in life that are inconvenient, but this is really what we need to do to make a change. Not everything can be convenient, comfortable, easy, quick. You know, life just doesn't evolve that way. Yes, yes. And we were discussing earlier how useful bilateral is as well. You know, if they have one thumb that's very unstable and one that's stable. Yes, no question. The overflow on both sides of the brain, no question. Yeah. I wore the brace for 18 months. I just chose that arbitrarily, okay? But I don't know how to determine how long an individual needs to wear it. And I think the only way is to have them wear it and then come in and have them do something that spontaneously loads them where before they would have collapsed and see whether they're able to hold their posture or not. I think a lot more work could be done in that area. I think we could perhaps better define that or have some better evaluation.
I think it's would be a very good setup for a prospective study.
I think it'd be fabulous.
With and without mirror training. It would probably take quite a lot of time.
I think one of the problems is if you look at the CMC literature, there are no long-term studies. And we're talking about a long-term problem. We know absolutely that we can diminish the symptoms. I don't think that's the core of what we need to be doing, is just diminishing symptoms. I think we need to create a better long-term outcome. But no one has measured it long enough term for us to know.
But I mean to see if with
Yeah.
the timing can be different.
That, yes. But I think just even the use of intervention for CMC also can be one of the things we need to look at. But we need to look at results long-term and include the posture along with the pain, maybe.
Using the mirror training, you would have to make sure that they've got a stable hand to mirror. If you've got two bilateral hands that are unstable, you're going to suddenly have to learn one of the hands to be stable to use it in the mirror.
We could probably do something with AI in this field as also.
Oh, maybe.
Or
yeah.
with virtual reality or something. Yeah.
All of you now must take this information, and it's your job to carry it forward, okay? To give it to someone else and to expand on it and to hopefully create the direction of how we are taking care of thumb CMCOA.
I was just would like you to tell the group that it is okay to use manual muscle testing sometimes.
Oh, right. Well, you know, I always talk, I'm very emphatic when I speak. And today when I was talking about manual muscle testing, I was specifically making those comments about the muscles of the thumb. Okay, sure, you can test the FPL and the EPL. Those are extrinsic muscles, okay? But I wasn't saying manual muscle testing is bad or don't use it. It's critical when you have a nerve injury, absolutely. But you are not able in the human thumb to isolate out the little intrinsic thumb muscles. They're going to work as a group, was the only point I was trying to make.
Completely agreed.
Yeah,
Yeah.
yeah. And for large joints, you know, manual muscle testing is really a great way to know what's supporting the joint. It's just the smaller you get and the more complex, the harder it is. Especially when you have a lot of muscles going across 3 joints and 2 joints. And yeah. It's easier when you got a muscle that's just moving one joint.
You're rather testing, as Wim wrote, you're testing movements rather than muscles.
Correct, yeah, yeah. So take anything I said today, and it applies only to the thumb. Don't take it and say, well, Judy Colditz said not to manual muscle test. Because she didn't say that. Thank you. Coming is always great fun.